Hello everyone, thank you for coming and my name is Dr. Sanjay. I'm from Care Connect Clinic. We look after family medicine, so everything from babies to the elderly. Today we're going to be talking about two areas where I have a special interest in, osteoporosis and andropause as well. Let's keep it casual. If you have any questions along the way, if there's anything you want to ask, we can take up the questions along the way as well. All right. Sean had forwarded me some of the questions that you all had passed to him, so I'll try and incorporate that into the talk as well. Initially, I thought I'd have a screen, so but this is better. All right. I think it's more important that a lot of the screens, we've got charts and all that, which doesn't impact the person. All right. This way we keep it more casual, and if there's anything you want to ask, just raise your hand, we can take up the questions. All right, we'll take it from there. We'll start with andropause first. It's unfortunately only affects the men. The ladies can listen in. Not so much a concern for you people, but for the men, it's something that all of us will encounter. All right, it's something that we have to deal with as we get older. The way we're going to do this is for both osteoporosis and for the andropause talks. We'll talk about what it is, who's at risk. All right, why are we all here? What causes these things? How do we assess? How do we test whether we have these problems? And then we go on to discuss the treatment options available. All right. So andropause, it's in a way like male menopause, but different, right? Females, when they encounter menopause, it's like driving off a cliff. The eggs run out. Once there's no more eggs, there is no more testosterone there is no more estrogen production. Progesterone levels drop very sharply the minute you cross into menopause. For men, that doesn't happen. All right, our testes that produce the male hormone will keep on producing, and theoretically, it can keep on producing all the way until you're 80 years old. All right, there is a steady decline. But statistically, up to age of 70, 75, it's only about 1 to 2% a year, right? Still adds up, we hit our peak levels around the age of 30. Sometimes different papers, they'll tell you around 20, around 30, thereabouts. But every year thereafter, it drops by about 1 to 2%. And we can slow this down, but it's going to happen anyway, right? These are part of the aging process, all right? The things that impacts andropause most significantly, other than age, is obesity, all right? So the bigger you are, the chunkier you are, the higher the risk, all right? Diabetes, that also affects the rate of decline of the testosterone and all that. And more and more of late, stress, right? That's a very big factor. It affects all your hormones, and in particular, testosterone as well, all right? There's a strong link between the stress hormone, cortisol, and testosterone, all right? We'll talk more about it in a while, all right? Now, testosterone, what is it? It's the male hormone, also found in females. It's not only in the males, but the differential is 20-fold. Right? Men have 20 times more testosterone than women. And it does very different things in men versus in women. With the low levels in women, it's not going to help you build muscles or that kind of thing. Right? For women, the equivalent hormone is estrogen. It's the anabolic hormone in women, whereas testosterone is the anabolic hormone in men. All right, and the common idea we have is that it's going to affect our sexual functions. Yes, it does, but it does a lot more than that. It's not just the libido and the the sperm production, the erectile function and all that. It does a lot more than that. Heart disease risk is lower when your testosterone levels are adequate. It goes up when your testosterone drops. Osteoporosis, all right, what we'll be talking about later on, affects men too, but it tends to affect men especially when the testosterone levels are low, right? And if we can maintain a good, healthy testosterone, then your risk for osteoporosis is very much reduced, all right? It affects the muscles as well in many ways, all right? Muscle bulk, muscle endurance, muscle strength, to be able to keep on doing things. All of these are impacted by testosterone, right? And that's also why testosterone is banned in weightlifting competitions and all that. So that's always a dilemma, right? I've got bodybuilders who've asked me, can I take testosterone? Will it help me get chunkier faster? But that's not the intent, all right? What we want is a good, healthy level of testosterone so that you don't have symptoms of deficiency, all right? That's physiological. That's what is optimal for your body to have, all right? You have that high level and it's a disaster waiting to happen. We had a patient like that. I'll just recount you a story. The patient ended up with a skiing accident, ended up in hospital, and the patient was crashing, His blood pressure was so unstable. He was having difficulty with the wound healing. The wound wouldn't close. The bone fracture got dislodged the first time round. And the doctors couldn't understand. When he came in, he looked so, beefed up and all that. And they thought he'd make a quick recovery, smooth transition, and then he'll be home. But everything started going wrong. And it was only later on when they started trying to figure out what's the story that they realized that he's checking himself with testosterone all the time. And when the accident happened and he couldn't get his testosterone shots, that's when you find all the deficiency problems come about, all right? Because when your testosterone starts to drop, it affects all your body functions from the healing and all that. So that's why it's important to understand you don't want artificially elevated levels that will help beef you up, build muscles fast. Really, shortcuts are not worth it, all right? And the problems that you encounter with it are not worth the risk, all right? One of the other aspects of this is the testosterone also gets converted to other hormones, right? And these other hormones, the common ones that are of relevance, DHT, dihydrotestosterone, that's the one that can contribute to hair loss, right? Or to put it correctly, you lose your hair at the top of the head. It starts coming out in your earlobes, on the back, everywhere else that you don't want the hair. So it's like that. The same hormone, but it does different things at different sites, all right? So testosterone converts to DHT. It can also convert to estrogen, all right? So one of the other big problems that comes about with testosterone replacement therapy is that your estrogen levels can go up as well. What that does in men is you get the man boobs coming up, all right? And not the most appealing lah, but it has other dangers as well. Because of the high levels of estrogen, in men, your risk for developing breast cancer is higher as well. All right? And the problem is men hardly ever screen for it. Right? And that's why breast cancer in men is a very often undiagnosed problem. You go to a doctor, you say, I got chest pain here, I got a lump here, or did you hit yourself? You know, it's more a concern about whether you had any trauma or injury. No one thinks about breast cancer. But breast cancer can happen in men too, and especially so when you have high levels of estrogen. All right? So these are some of the things you want to bear in mind why it's not a safe option to think about testosterone outside of the normal range, right? We can talk about physiological replacement. You want to top up the testosterone levels to within the normal range, but not exceed the normal range by 10 times or that kind of thing, right? So what happens when testosterone levels drop? Yes, it can affect your sexual function. There is a tendency for a decrease in libido. There's a tendency for erectile dysfunction as well. That can happen. The commonest thing that a lot of men might notice is the early morning erection is not there, right? When we are younger, every morning you wake up, you've got an erection, and sometimes it's a bit embarrassing. You have to hold a towel and walk to the toilet, that kind of thing. But as you get older, that morning erection is not there. And that's one of the easy telltale signs that your testosterone levels are dropping, all right? There are tests that we can do to assess these things as well. There's a little ring we put around the penis when you go to bed, and it will measure whether how many erections you have through the night and all that. So there's many ways of assessing these other functions, right? This is to assess end organ response to the testosterone. So testosterone levels is easy, well, it's simple enough to measure, but what you get in your testosterone result is also difficult to interpret. We'll come to that in a minute, all right? So, yeah, decreased libido, erectile dysfunction. The testes can shrink in size as well as we get older with reducing testosterone levels. But beyond the sexual functioning, it affects us in many other ways as well. There's a tendency for a brain fog. You know, you feel like you can't focus, you can't get things done like this, like you used to when you were younger. There's a tendency for low energy. The mood can get affected. It can even end up causing depression and all that. It affects your muscles. Muscle mass tends to drop. It affects the bones. Bones get weaker. It affects your fat tissues. It builds up excessively. You know, that paunch that comes about is part of testosterone as well. And one of the other common things that a lot of guys have is with a drop in the testosterone is after meals, you feel like you just need to take a short nap. You know, that power nap in the afternoon becomes an excuse to say, I'm crashing, I need a time out. And that tends to happen with the drop in testosterone levels. All right? Now, how do we assess? Okay, so when we talk about testosterone testing, all right, the common blood test that we do is testing for total testosterone, right? But that's not the full story. The total testosterone, 98% of it is bound to proteins, which means essentially it's useless, it's not doing anything. And there's 1 to 2% that is in the free state, and that is the active component, right? Only 1 to 2%. And the 98% is bound typically to SHBG, sex hormone binding globulin, right? And these SHBG levels increase with age. So you've got a double whammy, right? Your testosterone levels are dropping, your SHBG levels are going up, so your free testosterone is crashing very fast because both are acting against you, all right? So if you really want to assess the free testosterone levels, then that becomes a bit more difficult. Overseas, they do salivary testing. What comes out in the saliva is only the free testosterone. The bound testosterone doesn't come out. And that's the one that's actually doing the work, all right? Locally, we don't do that assessment. So the next best thing is this thing called the FTI, or Free Testosterone Index, which is your total testosterone divided by SHBG. And it gives you a number that you can work with that can help guide in decision making. Part of the problem is two different individuals with two different activity levels can have very different testosterone levels, right? If you look at the range of testosterone that is normal, it's a huge range, you know. You take the lowest number and you multiply it 5 times, you're still in the normal range. But that doesn't make sense, right? You cannot have a number that is so small and still say, oh, you're normal, and 5 times of that and still be normal, right? Why that big variation? Because when they do the normograms for the testosterone levels, they take everyone, you know, from the couch potato who doesn't move at all from the couch to the you guys who are working out regularly and all that. And they take the 10 to the 90th percentage of these population, and that's your normal range. That's why the big variation. The truth of the matter is, for most people, especially the active guys, you want your testosterone in the top quartile, the top 1/4 of the normal range. And that's when you'll be functioning at your best. Anything outside of that, you know, if you're at the lower end of normal, yes, you know, as your doctor, I will still have to tell you, strictly speaking, you're in the normal range. But we need to then listen to your symptoms. If you're symptomatic, if all your symptoms speak of andropause, then we should consider testosterone replacement, right? Typically, when we do testosterone replacement, we also want to make sure that your estrogen levels are within the normal range before we start topping up the testosterone. We want to look at some of the other hormones and all that as well, so that when we treat the testosterone, we don't run into other unexpected problems, right? So a good idea to do the complete set of tests so that we have an understanding where we're starting from, right? Now, when we talk about testosterone replacement, I'll deal with the easier part first, which is the medications. There are many different options. You've got everything from tablets to sublingual drops to patches or creams. There's a pellet you can put under the skin. When you have this many options, the only reason is because there is no one optimal option. None of it is perfect, right? One of the biggest problems with testosterone, especially when you take it orally, is it's fat soluble. So if you don't take it with a proper fatty meal, the absorption is very poor. It's just going to pass through, and you know, you're not going to feel any benefit at all. But if you eat that much fatty food every day, you run into a whole set of different problems, yeah? So really the transdermal is an option, but for most guys, you know, we're not in the habit of putting on cream every day, you know? So even if it's medication, you still, and after a while, very often, it lapses, they forget to take, and then you don't get consistent results. So for most guys, the easiest option is injections, all right? The newer injection is once in 3 months, typically. And that gives you a good steady state most of the time. that would be the ideal option for the majority of men. All right, there are a few others that can be every 2 weeks, every week even, but these are not intended for your normal steady state. All right. Then so that's the medication part. Or sometimes when we look at replacing testosterone, we also need to block the estrogen pathway, right? So that we don't end up with man boobs and all that. And there are creams we can give, there are medications we can give for that. But all this needs to be discussed with your doctor before you start the treatment and all that, yeah? But other than the injections, what else can we do, right? This is one of it, right? Working out, especially resistance training, is the best thing to get your estrogen levels up naturally, all right? It's very, very useful, specifically resistance training. HIIT, high intensity interval training, is also found to be very useful, but any kind of exercise will help. So must be active, right? Of late, the other very, very important thing to emphasize would be to sleep well, right? If you don't sleep well, if you don't manage your, well, that's point 2 and 3, huh? Sleep well and minimize stress, right? Stress just kills cortisol, right? Your stress hormone, cortisol, when it goes up, it's going to push down on your testosterone levels, right? And if your stress hormone's up all the time, you can bet your testosterone is down all the time, right? The other important thing to bear in mind is testosterone production is highest in the middle of the night, all right? It happens most during REM sleep, rapid eye movement sleep, which is your deep sleep. Now, if you're not going to get into deep sleep, you're thinking about work and the problems and how to solve this and that and the other, you can imagine what's going to happen to your testosterone levels. It's never going to be at its peak, all right? So the basic concept, sleep well, and that also means sleeping on time every night, sleeping in a proper darkened room, sleeping with, so you want to facilitate going into REM sleep lah. So there's a whole topic about sleep hygiene and all that you can read up about, and that will help facilitate your testosterone levels to come up naturally, right? So exercise, minimize stress, sleep well. Then next is your diet, eating healthy, all right? You want good healthy proteins, good healthy fats, all right? Cut the carbs. The carbs you can do without. Many of you may have heard about the keto diet. That's what this is about lah. You want that proteins and your healthy fats to come up, and that will help with helping the body to make more testosterone as well. Vitamin D is involved as well. Getting enough vitamin D will help tremendously. Other supplements are also recommended. There are studies, that show some moderate to good results with zinc. Other herbal supplements are commonly used, like saw palmetto. Ginger is used as well, and ashwagandha. And these are all supplements. So, good to consider trying them out if you are looking at helping the levels to come up. And the last bit is alcohol and smoking lah. So if you can cut down on this, that will help as well. All right. Each of this is going to have a small impact. So it's not enough to, oh, but I sleep very well, I sleep 12 hours every day, but you don't do anything else, then that's not going to work, right? Each one plays a small part, and all of it comes together to help your testosterone levels come up. So you want to try and do as much of it as you can, and that can help, all right? But if you are symptomatic, if your test results show that the levels are indeed very low, do speak to your doctor about formal testosterone replacement lah. That's the good definitive way to help get the levels up. All right? Any questions, anyone?
So, hi Doc, thank you. If you're feeling fine, is there any reason for like a normal man to get tested for the testosterone level? What circumstances would you suggest?
So, okay, the honest truth is you don't have to test, all right? Your standard health screenings most of the time does not include testosterone levels, all right? For the majority of men, we have no clue about what andropause is, and we never get tested and we never treat it. But we may still experience a lot of the symptoms. Now, if you're not experiencing any of the symptoms, then really there is no need to over-investigate. And in fact, even if you test and your levels are a little bit on the lower side, if you're feeling well, there is no need to treat. There is nothing to treat except the number, you know, and we don't treat numbers. You want to treat the person, and if you're feeling well enough, we don't need treatment, all right? For the some of these symptoms, unfortunately, are easy to hide behind other things, you know, like your libido going down, the erectile dysfunction. We've got a term for each of these things, and if you see a doctor for erectile dysfunction, Cialis or Viagra, and that solves the problem. But the underlying cause could be testosterone deficiency. You know, if you're having a brain fog all the time, if you're feeling that drowsiness after your lunch every day, these could be related to testosterone being low. We've had patients who, you know, were doing very well all along with their cholesterol, and suddenly the cholesterol just started creeping up every year. And he had taken on a new job, he's very stressed. Then he attributed it to stress. Yes, it can, but later on when we did a further test, we realized that his testosterone levels were very low. And that was probably contributing in a big way as well to his cholesterol levels going up. So it's this kind of subtle things that we are looking at, you see. It's not one clear evidence sign that will tell you that there's a problem. A lot of the things, you know, like the morning erections not being there, for example, it's something that happens as we get older. And to most men, oh, it's part of aging. Yes, it is, but the reason why specifically that is happening is the testosterone is dropping. And yes, you can write it and sweep it under the aging carpet, and it will just hide there all along lah. So again, you know, it's not something that we want to test everybody and get everyone screened and start treating everyone who has low results. But some of these non-specific symptoms that can masquerade as other things could very well have an underlying basis in andropause lah. Yeah? Right? Let's go on to the second topic of the day. If there's any questions later on, we can come back to this as well, yeah? The other part of it is osteoporosis, all right? Now, what is osteoporosis? It's basically, in very simple terms, is a disease process affecting the bones. The bones are getting more fragile, they're getting weaker, more prone to fragility fractures, all right? What does that mean? Non-significant trauma that results in a fracture, all right? How bad can it be? We've had patients who had a bad cough and ended up with a vertebral fracture. that's how bad it can get, all right? Other things, you know, you sit down heavily on the chair, you can end up with a compression fracture of the vertebrae, a misstep, not a fall, just a misstep can end up with a fracture in the foot, that kind of things, all right? And it's because the bones are becoming very soft, very brittle, all right? And they're not able to take the regular stress and strain that we normally would expect them to be able to take. Now, the thing to bear in mind is our bone is living tissue, right? And that makes all the difference, okay? What that means is, you know, personally I used to enjoy the Jackie Chan shows, you know, the karate and all that, and they'll show this wooden tree and they're just kicking the tree, and what happens? They get big bumps on their shins, you know. These are bone growths on the shin that your body will respond to the repeated impact and strengthen up that part of the body, right? That bone gets stronger so that you can continue kicking the tree, all right? But in the same way, if you translate that to weightlifting, all right? When you're lifting weights, the first few times you start off, your bones will realize, oh man, I'm not cut out for this. I need to get stronger. And that's what they do. They get stronger. They build up more bone, and that reverses your osteoporosis, right? It's not as easy as that. There's a lot of things involved. But why we talk about bodybuilding, Patricia, I am sure many of you must have, she was my patient. I'm so glad I referred her to see Sean, and that made all the difference for her, all right? She was osteoporotic range, not osteopenia. Osteoporotic, and she started weightlifting, and now you look at her, you don't think about osteoporosis anymore, lah, right? That's the difference it can make. She decided she didn't want medication. Doc, what can I do naturally to get my bone stronger? And that's what she did, all right? It makes all the difference. And why it works? Because your bone is living tissue. You just need to give it the right signals to get stronger, and it will do that for you, all right? The whole process about bones, we'll come back to it a bit later, but there's two main types of cells in your bones. The osteoclasts are the ones that will eat away at the bones, and then you've got your osteoblasts that will build up bone, right? And your normal aging process, your normal osteoporosis as we get older, happens because of an imbalance in the osteoclast activity versus your osteoblast activity, all right? What we want ideally is a situation where the osteoblasts are building more bone and the osteoclast activity is lower, is lesser in comparison. This happens until the age of 30. But after age 30, the osteoclast activity increases and your bones start getting weaker, all right? Other hormones are involved, calcitonin and parathyroid hormones. Estrogen is involved for most women. And that's why women are at higher risk after menopause, all right? When we talk about screening for osteoporosis, the risk factors, the very first risk factor is sex, right? Women are at higher risk, right? And this comes on after menopause, right? When your estrogen levels are not there anymore, then your risk for osteoporosis, the bone weakening, is significantly increased. For men, as we discussed, because the testosterone doesn't drop like that, it continues slowly, the risk comes on much later. So we start screening men for osteoporosis from age 65 onwards, whereas for women is around 50. You know, when you hit menopause, from then onwards, we should be screening you for osteoporosis already. All right. There's a whole bunch of other risk factors. We'll come to that in a while. But why we want to talk about osteoporosis, why we want to understand it, is because it's a silent killer. All right, it's a disease that lurks in the shadows. You don't know it's there until that first fracture, until that first broken bone, and then you screen, oh, suddenly you find out you're osteoporotic already, right? When you read the literature, they talk about bone pain and all that. It doesn't happen for most patients, right? It comes about especially when there's a sudden drop in bone density levels. Then you get that bone pain, all right? Cancer patients, that kind of thing. But for the majority of patients, when you are slowly dropping in your bone density, there is no complaints. So good to screen for it, you know, from the time ladies hit menopause or men hit 65 years of age, all right? Just to put things in context, the incidence of osteoporosis in fractures caused by osteoporosis is about 900 per 100,000 in women, all right? In women over the age of 50 versus 400 in men. It's less than half the number of men that get affected. So it's a big differential. But what I want to highlight is men don't think you are scot-free. It's still 400 cases a year for men above 50, right? 400 cases per 100,000 population. All right. So good to assess whether you are at risk or not. One of the other important things, you know, very often we think, oh, it's a big deal, it's a fracture. You just put metal plates and we go on with life. It's not as simple as that, yeah? If we look at the statistics for hip fractures in patients above 60, yeah, hip fractures above 60, 1/4 of the patients who get that hip fracture will die as a result of that hip fracture, right? Why that happens? Because they are bed bound. They get chest infections, they get urinary tract infections, and that's the end. 1/4 of patients will die from that hip fracture. Half the patients will never walk again. They may still be ambulant on a wheelchair, they may be bed bound, they may need a walking frame to get around. Half the population will not walk again. And you only have 1/4 of the population who have a hip fracture after the age of 60 who will be ambulant on their own again. Not very reassuring numbers, right? And as a cause of death, you know, a hip fracture that could have been prevented, you know, you really don't want to go down that road, all right?
Sorry, is this in all sexes, men and women?
Women. This study was with women, but really for the men, the start range wouldn't be 65, wouldn't be 60. It would start coming on later. All right. So see, the part of the problem is when your bones are weaker, the healing is poorer to begin with. So if you've got weak bone to start with, even after fixing and all that, the recovery is compromised. Whereas for men, the risk of osteoporosis starts after 65, right? Okay, so Who's at risk? We talked about women being at higher risk, especially menopause. So women who have early menopause are at even higher risk because you've got a longer runway to go. All right. If there's family history, if your parents, your mom especially had osteoporosis, then you're at higher risk of having osteoporosis as well. The older you get, the higher the risk gets. If you have previous fractures before, then your risk of having another fracture is higher. If you've had frequent falls, then the risk of having a fracture is higher. So all of this comes about as we get older. So where we can, if we can strengthen up the bones so that you don't end up with a fracture, all the better. But you want to do all the rest as well. Reduce the likelihood of a fall at home, having the support bars in the toilet and all that is so important, especially if you've got an older person at home. One of the other big things is prolonged immobility, right? Someone who's had a heart attack and is bedbound for 3 weeks, his risk of developing osteoporosis in that short span of time is actually very much accelerated because he's not doing anything, right? So for these guys, when they start their rehab, one of the things that you want to do is a bit of muscle building, get the muscles to recover, get the bones to recover as well. All right, all that is very, very important. Then there's another group of risk factors that are modifiable, that we can do something about. All right, and the most important there is your calcium intake, your diet, right? A lot of times, patients who are not taking calcium supplements or making a conscious effort to get enough calcium in their diet, they are at risk of osteoporosis. So, look at your diet, what your normal diet constitutes, how much calcium is there in that diet, and if it's not enough, then try to supplement, because if you're not taking enough, then your risk of having osteoporosis is that much higher, right? Having a low BMI is another risk factor. So if your body weight is low, then you are at higher risk, right? It's like just by having that slightly higher body size, you're doing weights every day. You're carrying that weight around with you all the time. That's going to stress your bones and make your bones stronger. Compared to the very petite patient who has very little body weight, the tendency is their bones are going to be weaker from the onset, right? So the risk for osteoporosis, the risk for fragility fractures is that much higher, right? What that means is I'm not proposing everyone start getting fat, right? That's not the intent, but start doing exercise, start putting on muscle mass, right? One of the other most important things about having good functional muscles is you can break that fall. You can prevent actually having that fall, I kid you not, I've had patients who tell me, I saw myself falling and I couldn't do anything to prevent it. Why? Because their muscles are just so stiff. Their muscles are not able to respond fast enough. And it's like in slow motion, you can see yourself falling, know what's going to happen, and completely helpless to do anything about it, right? So being active, having your muscles working for you is so important, right? Yeah, some of the simple ways we can assess bone density testing, your DEXA scan. I'm sure many of you would know what that is, right? But for the younger patients, for those who've not had a bone density test previously, some of the simple assessment tools. There's this thing called the OSTA, is osteoporosis self-assessment, self-test assessment tool for Asians, and it's very simple. Yeah, it's your you can do it yourself right now. It's your weight in kilograms minus your age in years. Okay, multiply by 0.2. Simple as that. So you do the maths, and if the number is less than less than meaning the results will be sometimes in minus, in negative arena. So if it's -1 and above, so -1, 0, or in the positive range, then your risk for osteoporosis is very low. So this one, the younger guys, you're not at risk lah, right? But as the age number gets bigger and bigger, and very often your weight starts going down, that's when the risk goes up. Range of -1 to -4, you're at medium risk of having the fractures. Anything more than -4, you're at high risk, right? And there's a simple chart that is available that has the red, orange, and green zones. Very easy to use. There's another simple tool that is available online. It's called the FRAX, F-R-A-X. And it will ask you a simple questions, family history, whether you've had any fractures before, age, weight, all these things. You just key in the numbers and it gives you a 10-year fracture risk assessment, right? And based on that, we can decide, is treatment needed or do we wait on starting treatment, all right? Now, how do we reduce our risk for getting fractures? There's the non-prescription methods. You want to make sure that your calcium and vitamin D levels are adequate, right? That's so important, all right? Not just calcium, but vitamin D as well. Now, one of the things that I would highlight here, I get many patients asking me, I just did my blood test and my calcium level in the blood test was normal. Then does that mean I don't have osteoporosis? What's the answer?
No.
Very good. It's the way I was asking you could tell already. But okay, but what you want to appreciate is that is blood calcium level, all right? Blood calcium levels will be maintained at the expense of your bone. Okay, you need enough calcium in your blood for your muscles to function properly, for your nerves to function properly, for your heart to function properly. And these blood calcium levels will be maintained within the range as much as your body can handle without regard to what's in the bank. Bank being your bones. Your bones are essentially just a reserve for the calcium that is available for the body to use. So your blood calcium levels has no bearing whatsoever on your bone calcium levels, right? The only way to assess whether bone calcium is enough or not is to do a DEXA scan. There are other ways that help you approximate whether there is enough or not, but the best is a DEXA scan, all right? Then, okay, so getting enough calcium and vitamin D, smoking and alcohol, that's everywhere. Especially for the smoking, it affects one of the key hormones, not hormones, one of the key enzymes that's involved in osteoporosis. So smoking is actually a high-risk activity for women and who end up with osteoporosis. And physical activity, right? Physical activity, the gym and all this is good, easy way to try and stimulate your bones to get stronger, right? Then the next part, we go on to the prescription medications for osteoporosis. There's two parts. The regular medications are what we call anti-resorptives, right? What that means is it doesn't specifically build bones, but it slows down the osteoclast activity. The ones that eat away at the bones, that activity is slowed down, and we leave the osteoblasts to do their work and hopefully build up the bone. But if the osteoblast activity is not strong enough, then you may not get that much of an improvement, all right? You end up effectively slowing down the osteoporosis, getting worse, but it may not improve so much, right? So most of the medications that are available belong to this class of medication, right? You've got your estrogen substitutes, things like Livial. Then we've got raloxifene. It's one of the medications we use for breast cancer, but it's also been approved for use for osteoporosis. All right, and then there's the whole bisphosphonates. There's multiple types. Once a month. There's a once a week kind. There's even an injection type. All these belong to the anti-resorptives. There's a newer agent which is a subcutaneous injection once in 6 months. That's very, very effective, very, very good, suitable for long-term use. But if you start on that agent, you cannot stop, right? So it's something that you want to discuss with your doctor before starting, because if you stop, then your bones will literally melt away, and you don't want that lah. You don't want a situation where your fracture risk suddenly goes up many-fold because you've stopped the medication, right? Then there are a few options which are anabolic that actually help build up your bones. One of it is a monoclonal antibody, the romosozumab, which our patient here is taking. It's a very good drug, and it really builds your bone up very nicely, but it's only for 1 year. And then when you finish that medication, you need to go on to an anti-resorptive to continue the treatment. And the other one is teriparatide, Forteo. It's also an injection. These are suitable to help build bone up very fast, but they are very limited indications where we would use these things. All right? But when it comes to the prescription part of it, really you want to discuss with your doctor. They will help make the decision what is the best option for you. All right? So, all right, we've covered a fair bit of material. Any questions on osteoporosis or andropause?
Previously you mentioned about treatment for testosterone. Are there people receiving this, do they need to be wary about any pre-existing conditions? Do the treatments interfere with, or have any negative effects for people with pre-existing conditions?
Yes.
Yeah, okay.
Okay. The biggest worry about starting testosterone treatment is if there's any prostate issues, especially prostate cancer, right? So, see, the basic principle about replacing hormones or that kind of thing, the target sites which that hormone is going to act on, you want to make sure that there's no abnormality in that target tissue. And for your testosterone, the biggest factor is prostate. The testes and all that, yes, they get affected as well, but testicular cancer is very, very uncommon. But prostate cancer is a lot more common than testicular cancer. And the treatment for prostate cancer is anti-androgen therapy. So before you start on testosterone treatment, you want to make sure that your prostate is healthy. If your PSA levels are borderline or on the high side, then that needs to be sorted out properly before you embark on replacement therapy lah. Right? That is the biggest thing. Other things like checking on your estrogen levels, your men boobs and all that, these are important as well, but the prostate is an absolute contraindication lah. Absolute contraindication. Cannot play around with that lah. Yeah.
But I want to ask about training for osteoporosis, right? Because, of course, we have a number of clients that come to this gym because of osteoporosis. And a common question that they ask is, how long does it take before, I can see result in my bone density getting better?
Okay.
Is there any kind of good answer that I can give to our clients that have this
Okay.
story?
So, while bone is a living tissue, it's going to take time to manifest a differential that you can measure. All right. The typical guide on how soon to do another check, if we are on medication, if we are on anti-resorptives and all that, the shortest interval is 1 year. In fact, typically, for most patients, we do it again in 2 years' time. That's the interval that it takes to manifest a difference on your reading. Right? It's not going to show up in 1 month or that kind of thing.
And that is only medication.
That's medication. So what I'm trying to say is, if you're hitting the gym to work on osteoporosis as a sole modality, if you do it in 6 months, it's going to be very disappointing because you won't see a difference. That may not be the truth. It may not be the true reflection of what's going on, but it gets very demoralizing when you don't see any change, right? A significant, the likelihood of a change will be there in 2 years, right? So don't rush it. Don't, oh, it's been 9 months, I want to check. No, you're just going to disappoint yourself, right? If you're feeling better, if you're getting stronger, if your muscles are working for you, that's enough of positive finding that you get. You don't need the bone density test to show you an improvement, right?
Yeah, maybe about the bone density and all this stuff. So, in relation to training, right? So, for example, if someone trained when they were young for many years, let's say didn't train 10 years or something, and now they're old, can we speak about any long-term effects from the past, or there will be any other old person? Is there any?
No, see, so again, there is a difference between the regular training benefits. You might notice the ones who've started young, who've done the training from a younger age, their body frame changes. You get the bigger shoulders, everything about the body frame will change, and those changes will sustain, right? The weekend warriors, oh, Sunday I got a free day, come let's hit the gym, that's not going to sustain, right? That can help build up the muscles in the short term, but it doesn't stay when you go off the training. The muscles melt away very fast, right? I had the opportunity to meet one of the ex-Singapore bodybuilders from years ago. He's like 70, 74 now, I think. But you look at his frame, you can tell he's worked out before lah. You don't lose that because he wasn't doing it, once a week or that kind of thing. It used to be almost a daily affair. So when it's that regular, the benefits of it, the changes in your body structure will remain. it doesn't go away even though you stop training. All right. The opposite is the ones who are injecting the testosterone. That one, the muscles literally melt away. You know, you stop taking the injections, the muscles are gone so fast. That's why when we talk about testosterone replacement, we're talking about physiological replacement. Replace to within what is the normal range, not 10 times normal or that kind of thing lah. All right. So you need to make sure that it's done correctly, properly, with proper screening. Make sure that the estrogen levels doesn't suddenly shoot up and all that. So all that needs to be balanced. Yeah.
Okay, so like in regards to bones, not only muscle but bones.
Yes. Same. So see again, the bones are your Reserve Bank of America. It's like where all your gold is hidden. When you're building out, when you're working out and lifting the heavy weights and all that, you need that bone strength to lift the weights, right? If you're lifting heavy weights, if your bones were weak to begin with, they would learn, I need to very quickly build up the muscle, the bone strength, so that I don't get adversely affected when I lift the weights, right? So they will get stronger. And because that's not done in a rush, it's done because you are doing that training, then it's going to remain stronger for that much longer. You have more reserves to call on, right?
So, earlier you mentioned the different parts that help, sleep, stress, exercise body. So, how much does a supplement help? Is it proven supplements actually help?
So the things like saw palmetto, ashwagandha, ginger, all these things, it's not part of mainstream medicine. But when you go to parts of Europe, Germany and all that, there is still a lot of traditional medicine that is still commonly sought after. There are still journals of traditional medicine, of herbology and all that, where they talk about these things. And those studies, you will find papers about how using saw palmetto has helped, that kind of thing. But it's not part of mainstream medicine. So really, I think personally, this is my opinion, Western medicine has a lifespan of all of 200 years. Before that, human beings walked on earth. Human beings fell sick and they sought treatment, right? You had your traditional Chinese medicine, your homeopathy, your Ayurveda and all that. And these have been around for eons, They've survived the test of time. Who are we to say that, no, that's not going to work for you, you need to take my medications? We don't know everything. The statins we take for cholesterol, it's actually based on a derivative from red yeast rice, which TCM practitioners used to prescribe to all their heart patients. Western medicine comes along and says, what's the secret in there that's making it work so well? And they find this chemical and then they bring it to the pharmacy and start a whole business out of it. And now that's your standard treatment for cholesterol. But it has a very sound basis in red yeast rice. So I have patients who have borderline cholesterol, don't want to start medication, start red yeast rice. It works. So, I mean, this is my belief. You are free to decide whether you want to consider trying out these things or not, lah. Yeah.
You say that strength training and conditioning helps with osteoporosis. like swimming, brisk walking, clothing?
So swimming is a fantastic exercise, but you're not loading the bones. You get what I'm saying? Just like the example I gave about, you know, kicking that tree to build up your bones in your legs, you know, to make it harder. You need that kind of loading. You need that kind of stress. So what happens is, when you stress the bone, it undergoes microfractures within the trabeculae, within the what if it gets worse, it ends up becoming a stress fracture. But at the micro level, you get these micro fractures, and then your body heals that fracture, and that's how the bone gets stronger. You know, it's like when you kick that tree, it's gonna hurt when you first start, right? But that hurt at the microscopic level has resulted in small fractures in the bone. And then your body heals that bone and lays on extra layers for that more strength. So you need that loading of the bone. So swimming is a good exercise, fantastic for the muscles and all that, but doesn't help the bones so much. You need to load the bones. All right? All right. You have it? No? All right. Thank you all for coming. Thank you for your attention. All right.